The second case is a 28-year-old male who's stabbed in the left flank. So his history, altercation, always with two dudes. He felt a sharp left flank pain, and then he fell to the ground. He has some dyspnea and pretty severe left upper quadrant pain, as well as flank pain. He denies any other injuries, didn't lose consciousness when he fell, no neck or back pain. On exam, lung sounds a little down on the left, normal on the right. Trachea is not deviated, there's no elevated jugular venous pressure. The abdomen, however, is pretty significant. It's rigid and it's tender. And he doesn't like you touching, he's guarding that abdomen. Pulse quality is weak and very thready. Cap refill is 4 seconds. Skin is cool and pale. Vital signs, blood pressure is 82/40. We seem to like those blood pressure numbers. Pulse is 130. Respirations are 24. And then the SAT is 94% on room air. So not a bad SAT given the entire situation. Any other assessments? Well, you can think of, again, point-of-care ultrasound that may help figure out if there's a pneumothorax present, that may help figure out if there's a pericardial tamponade. Now, there's no jugular venous distension, which is good, but he got stabbed in the left flank. We don't know how long the knife was. We don't know the specifics about it. It's possible that the heart may have been tagged. So point-of-care ultrasound might help, and then end-tidal CO2 might help monitor the perfusion real time. So differential diagnosis, we got a left flank stabbing. So we likely, based on the clinical picture, have at least a small pneumothorax. The other thing is we may have left kidney injury. We may have a left spleen injury, or we may have perforated bowel as some of our differential there. Oh, and I forgot, I mentioned possible myocardial injury. So what are the treatment priorities for this patient? They're in shock. So we're looking at IV fluids, permissive hypotension, TXA. For that, we're looking for some O2. He's got a reasonably good saturation, so we may not need to give him huge amounts, but again, for a relatively short period of time, putting an on rebreather on, we don't know how much blood has been lost. We may have a good pulse ox, but if our hemoglobin, which is normally 14, is down to 8, that's a lot less oxygen carrying capacity. So the extra oxygen may be helpful at this stage. And then packaging and transport. What are we going to reevaluate? We're going to reevaluate the data, including the vitals, end-tidal, and point-of-care ultrasound. And then finally, this is another patient that needs a trauma center